Hi, I'm Dr. Marty Weiser. I am a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center. My interest and expertise is in intestinal cancers, including colon, rectum, small bowel, and appendix. What's the role of surgery in anal or perianal squamous cell carcinoma? Treatment is based on location and size of the primary lesion and presence or absence of local regional lymph nodes. The perianus or anal margin sits outside the anal canal and is easily visualized when the patient is in the lateral position. Small lesions outside the anal canal involving the anal margin and without local regional lymph node metastases can be treated with simple surgical excision as long as the sphincter complex is not involved. That is, these patients are treated like cutaneous squamous cell carcinoma. For larger lesions or those with pelvic adenopathy or encroaching on the sphincter complex, such that internal or external sphincter would need to be removed for a clear margin, we would treat with definitive pelvic chemoradiation. What you want to avoid is attempted resection with removal of this part of the sphincter complex and without achieving clear margins such that pelvic radiation is necessary. Pelvic radiation following partial sphincter resection is associated with very poor bowel function. Most lesions involve the anal canal and are palpable with digital rectal exam and are seen only by anoscopy or proctoscopy. And these lesions should be treated with definitive pelvic radiation. The rationale is that deep to the anal canal mucosa is the internal sphincter, and trying to achieve a clear margin would require partial sphincter resection. Removing any portion of the sphincter will affect bowel function, and radiating following partial sphincter resection has poor bowel function. Now, an exception is a very small lesion found in the anal canal and removed with excisional biopsy. Here, if there's superficial invasion with clear margins, pelvic radiation may not be necessary. What's the follow-up for anal cancer? Following definitive pelvic chemoradiation, often Xeloda and mitomycin, I see patients in the office for evaluation at 3 months, including digital rectal exam, anoscopy, or proctoscopy. I then follow patients closely every 6 to 12 weeks until there's evidence of a complete clinical response or lack of regression and progression. If patients continue to respond, they are followed. If response stops or there's progression, we proceed to surgery. I usually perform biopsies before proceeding with abdominal perineal resection and permanent colostomy. For those patients that achieve a complete clinical response, they enter surveillance. For the first 2 years, patients are evaluated every 4 to 6 months, including digital rectal exam and visualization with anoscopy or proctoscopy. Following 2 years, patients are evaluated every 6 months. Surveillance biopsies are not routinely performed unless I'm considering going to surgery. Surgery, including abdominal perineal resection and permanent colostomy, are for patients that do not have a complete response or have regrowth following a complete response. And as mentioned, I usually perform biopsies before proceeding to surgery. Surgical planning for surgery for anal cancer patients. Now, there's differences between radiation for rectal cancer and anal cancer that are important for surgical planning. The anal canal is usually spared for rectal cancer, but may be boosted for anal cancer. This can result in anal margin fibrosis and reduced wound healing. In addition, anal cancers have a higher risk of pelvic floor involvement or vaginal involvement in women. For these reasons, wide cylindrical resection may be needed with flap reconstruction, such as VRAM or gluteal, to reconstruct the vagina and to facilitate pelvic healing. However, in some cases, primary closure with or without an omental pedicle flap may be sufficient. Depending on pelvic floor reconstruction, hospitalization is longer than rectal cancer resection. Long-term pelvic drainage is usually necessary to facilitate healing, and sitting is restricted for 4 to 6 weeks. There's a 25% risk of pelvic sepsis related to poor wound healing, requiring debridement and wound packing, and convalescence often takes 3 months. Unfortunately, anal squamous cell carcinoma requiring abdominal perineal resection is associated with a 50% risk of distant failure, and this will affect long-term surveillance protocols.